Assalamu alaikum everyone. Welcome back to another episode of the Medical Talk. Today we have a very special guest with us, Dr. Sadiq Naveed. Dr. Sadiq Naveed is the Associate Professor for Psychiatry as well as the Program Director for the Psychiatry Program and is also the Chair of APPNA YPC, and I'm very honored to have him here today with us. Thank you so much for joining us.
Thank you very much. Thank you for inviting me.
So we usually start by talking a bit about early life so we can understand a bit about how the events in your early life led to your decision of becoming a doctor and pursuing medicine.
Yeah, so that is very comprehensive question. And we can talk probably throughout for 30, 45 minutes on that. I was born and raised in a small city, Rahim Yar Khan. So I did all of my schooling there, my FSC from Rahim Yar Khan in a government school. So it was in a private school early on, and then from 6th grade, I moved into a government school, and then FSC, that's something I completed in a government college. There's only one government college in Rahim Yar Khan. So that's where I completed that. Decision about becoming a doctor. I think a lot of us, in our cases, that comes from family. And then, because we are so used to hearing this, we generally become attuned to that. In my case, when I just remember when, I started my FSC, I was really good at maths. And I decided I made a change, that I want to study maths, and I want to go on that route. So in Pakistan, in FSC, you take a lot of tuitions. I don't know how the environment is today. So I started that, and then I did probably, those tuitions for 1 to 2 months, and then I changed my mind. I said, I want to go back to medicine, and a lot of my friends, they were also doing medicine or doing pre-medical at that time. So that's how I landed in doing medicine. I did medical school from Nishtar Medical College, Multan. That's where I spent 5 years of my life. And after that, then, it was a whole journey. And roughly after my final year, that's when I decided I want to do USMLE and I want to pursue that route.
That's really nice. My grandparents, both of them, were also from Nishtar Medical University in Multan. So I've heard a lot about it and a lot of stories. How did you decide that you want to go to the US, and what was that move like?
I think the topmost reason was to get better training opportunities. Frankly speaking, when we were doing our house job, most people were doing unpaid house jobs, and there was a lot of saturation that was happening at that time, and with it's probably worse now. So that's when I decided that I want to go abroad, and at that time, one of our seniors from that school, they went to do PLAB, and they settled in UK. But in our fourth year, final year, there was a change that was made in taking medical graduates outside of the European Union. And that's sort of made things difficult for people coming outside of the European Union. So, people from King Edward, Dow, and Aachen were doing USMLEs prior to that. So there was a culture that existed there. So after that, there was shift in Nishtar too. We saw a lot of people actually doing USMLE. So because of that change in the processes for European Union, it seemed like, maybe USMLE is a better opportunity. So that's how I decided to do USMLEs. Now, someone will ask whether, at that time you wanted to settle in US. I did not have that on my mind at that time. But that's something that came more apparent. But at that time, I think the purpose was just support yourself and get better training.
I think it's the same reasoning right now for a lot of medical students as well. Whenever I talk to my seniors, they also have the same reason, that job environment is very saturated and the pay is also not sufficient to support a family or even support sometimes yourself. So a lot of people choose the USMLE pathway for that.
Yeah, correct. And I think I really applaud those people who are working back home. Our resources are limited. You do get, a lot of good clinical experience back there, but resources are limited. It's very tough to work in that infrastructure. So I really applaud those people and cherish those people who are able to serve the nation. And that's the only part of that's only some guilt that I have. I owe a debt to my country.
But while you're in the US, you are helping a lot of medical students here in Pakistan, like myself. What has that experience been like, especially with APPNA YPC? It's a big organization. What has your experience been like as a chair of the APPNA YPC?
So like I said, it was you hold that guilt in yourself that you moved away from your country, so you do want to serve your country. In my residency and fellowship, I was doing some work, but at individual level. But I feel like, to increase the outcome of your work or things that you're doing, you need an organizational platform. And at this time, I'm very proud to say that APPNA YPC is one of the most vibrant committees in APPNA, especially in last 2 to 3 years. Work was even happening before then. There was a lot of activity that was going on. But I think we have a lot more tools that are available for virtual communication. So it has made job very easier to communicate with young medical graduates and support them. So I felt like, if I will work on an organizational platform, that would probably increase the chances of communicating what we want to communicate with younger graduates. And I think APPNA YPC has taken a new turn in the last 2 years, and credit goes to Dr. Numara Jamshed. I don't know if you heard about her or not, but I think she made some very insightful changes last year. So we are just trying to sustain the momentum and build on the work that was done in the last 2 to 3 years.
For sure. I think APPNA YPC is an amazing platform. And I think it's very important because sometimes you do feel isolated while being in Pakistan and applying for the match. You talked about that recently in a Twitter thread, that there are some things that really need to change with respect to how IMGs match in the US. So what are your thoughts on that? And what are some of those things that you want to see change in the next few years related to IMG especially?
So I think you're referring to that tweet that there are some written and unwritten policies among institutions against US IMGs. I think in US the disparities exist. It is a country with endless opportunities, but I think we always continue to strive for excellence, and that's where that tweet came from. So, for example, if I give you an answer. So recently, when we were doing our USMLEs and residencies, non-USMGs have a path in, but you will see a lot of programs saying that, you need to have 2 years of clinical experience to be considered for interview. And that experience cannot be observerships and externships. So there is no way that a non-US IMG be able to gain that experience because observerships and externships are usually not that long, and then they also put a limit on graduation on those times too. So I think field is uneven, though the match rates are holding up for IMGs. Every year we see about 55 to 60% of IMGs still matching into different specialty. It has become competitive, and when we talk about IMG, is a big pot, right? So it has US IMGs, in US IMGs you see a lot of Caribbean graduates who actually do their clinicals there, so they are at advantage compared to non-US IMGs. And then there are non-written policies too. I just gave an example of something that is written that exists there. Even the programs would say that if they take applications from non-US IMGs, they would not consider them for interviews. And that's something that happens internally. So we really don't know about that. So I think my hope is that you don't consider someone for an interview based on whether they are IMGs or AMG. you consider them based on their application and their credentials. If non-US IMGs don't have a great credentials and you got someone who is US IMGs or AMGs, please do consider them. So we just want to be considered evenly. We are hoping that we will be considered based on credentials and would not be rejected based on that this person is an IMG, or create some sort of hurdles for IMGs. And there has been some shift in policies by AMC and ACGME. They do ask questions on disparity. And this disparity does not exist only for IMGs, ethnic minorities. They also struggle with, like, Blacks and African and American Indians, Hispanics. They do struggle with equal representation in the field. So they are considered minority in medicine. Their numbers are far lesser than their population percentage.
I think there should be a level playing field for all applicants based on their credentials. I was listening to an interview by a program director from the US, and he said that for me personally, a person who has a visa and does not require a visa process from my program is not someone who would be my first priority. I would rather choose someone who does not require a visa and is already a US national.
Yes, yeah, and that's the hope for. I will not say more because my institution also, we have a family practice program, and they don't take people who require visa. So I'm hoping we can shift that a little bit, at least take people on J1 visa. But I also think there has been a lot of struggles with for example, last year, roughly about 30 incoming PGY1, their visa processes went into administrative processing. So that really made it difficult for programs, right? So when you have resident who cannot join, it really puts more workload on others. And unfortunately, 2 people they lost their contracts because of the visa issue. So I would see where that hesitation coming from, but I agree with you. I think these processes can be smoothened, and it does help in a lot of ways to developing countries to bringing their workforce, optimizing their skill set, so it can really improve the global health.
That makes sense. I feel like it's a very difficult situation, but things are getting better. And inshallah, in the future, I think things will only get better. When we're talking about IMGs, the step 1 exam is now pass fail. What are your thoughts on that? And how do you think that applicants can do other things that will help them stand out among all of the other applicants now that the score has been eliminated?
Yeah, so I think first we need to understand what was the reason for going from 3-digit score to pass fail. It does hurt IMGs in a way because you have one less matrix to show your strengths, but the reason was they want to see physicians who can exhibit humanism, compassion, warmth, those humans and good physician skills that someone can have. Now, how to tackle that? I think one thing that we need to probably now appreciate is that, with USMLE step 1 being pass and fail, and with CS not being there, the year of graduation is going to come down. So mostly people are going to be able to complete their USMLEs within a couple of years. So program's going to look for fresher and fresher graduates. So if someone is planning to do USMLEs, they need to sort of start working on it early. So for example, take USMLE step 1 at the beginning of the final year, or at the end of the final year, and then take step 2 CK within 5 to 6 months whenever they can. I will also say that people should do house job because that brings clinical, that adds up to your clinical skills. And also with the visa delays, you don't know what's going to happen. Now, what else can be done? A lot can be done. Something what you're doing, increasing the awareness around USMLE process, and also medical topics that can be done. So, and other things, for example, being more present in societies, clubs, and being engaged in their activities, taking a leadership role, because while you can display it in your resume, I believe that even if you're on leadership position at a very small organization, you learn a lot of good skills, right? So you learn how to do the conflict management, you know how to bring people together, how to be organized so you can achieve the goals that you want to achieve. So leadership, medical startups, any sort of awareness campaigns that you can do. So for example, in psychiatry, that is my field. People can do campaigns, more organized campaigns to raise awareness around mental health and target and address the stigma that exists in our society. That is one example. Research, being engaged early in the scholarly process, reaching out to people and see if you can work on any research projects. And I think this is something that doesn't end or stop with the match processes. If you're going to be staying in educational atmosphere or academia, that's going to be needed. So learning those skills early on, that would really help. So, and then, see what kind of clinical experiences that you can gain. For example, for undergraduates, electives are there, sub-internships are there. After graduation, you can go for externships, observerships, research opportunities, and the importance of each one varies depending on specialty, depending on year of since graduation. So I think there are a lot of things that you can do, but when you look at ERA's CV, and I will appreciate, or if you can ask someone to share their ERA CV, what are things that are on ERA's CV. So for example, it does have, besides your USMLE scores and other things, it does have volunteer experiences on it. So you can add all those things that you did. It does have work experience that can include any sort of internships, sub-internships, electives, observerships, externships. If you did any sort of other jobs after graduation, there is also an opportunity to list research experiences and publications. So just know those and see how you can address that, but have a story to talk about, right? So what is your story? And being able to relate that story, that really matters. And in this whole process, you will develop connections, and they do really help. It doesn't mean that, if you don't have connections and you have really good resume, you cannot match. You can, but connections really help you to connect with people, because roughly there are many applications that programs receive. For example, for psychiatry, an average program will receive about 1,000 applications. So how to be visible in those 1,000 applications, it will be helpful if you have someone who can advocate for you.
That's really nice. I feel like if you start focusing on learning new skills from the first year or second year of medical school, I think it really helps.
Just to give you an idea, so for example, we go to med school at probably age 16 or 17, right? Maybe 17 or 18. American medical graduates, they go to medical school, they do high school roughly about at 16 or 17, they do 4 years of college, and then they go to medical school. So developmentally, when they are applying for residency, they are probably 25, 26, but we are 21 and 22. So there is a developmental gap. A lot of growth is happening in adolescence and young adulthood. So we have to play catch up on that aspect too. So that's where we can probably gain those experiences by being engaged in these sort of activities.
Dr. Naveed, you talked about doing a house job. Do you think that home country residency helps when applying for the match? Because it takes a lot of time, and then your year of graduation also matters. So what are your thoughts on that?
So I think, let's answer it a little bit differently. Let me answer this, whether home country experience is needed. I don't think home country residency is needed. Obviously, do house job, and so if something happens with the visa processes, and I'm talking from the context of Pakistan here, because Indian medical graduates, they do their internship as part of their medical school, right? So from Pakistan, we do house job or internship after we graduate. So I think house job should be done. Maybe you can take step 2 CK before then, if you have done step 1 in your medical school years. The house job, let's say something happens with the visa processes, then you can resume clinical experience if something happens there. And also, by doing house job, you have something to list on your ERA CV from clinical experience perspective. Whether it trumps US clinical experience, probably not, because with US clinical experience, you get a letter of recommendations, you get the clinical experience, you get to work in a US healthcare system that puts you at advantage. But I think people should be doing house job. That's consensus among members of YPC too. Now, home country residency, which you are talking about FCPS, people match all the time with without doing FCPS, so I don't think it is needed. What if someone has done FCPS and they now want to pursue USMLEs? There are different pathways for that. Earlier, I was talking about year of graduation, so your application might be screened out if a program is using a filter of year of graduation, right? So now the one thing that you can do is you can reach out to the program directors outside of the match by an email, giving a brief snapshot of what you have done so far, and telling them that I have done home country residency. I'm really interested in the specialty. And can you review my application? So usually then they can review your application and they can extend you interview too. There are also some direct fellowship pathways too. So for example, this year, a person who has done who was ECFMG certified, he has done FCPS psychiatry in Pakistan, he matched into forensic psychiatry fellowship. So there are paths that exist in that way. One of my friends who did FCPS in pediatrics, she was exempted from doing PGY 1 year. So she can apply for PGY 2 years. So people who are doing home country residency, if they change their mind, there are different pathways that they can adapt. But you don't need to do home country residency if your plan is to be coming to US to do USMLE and then residency here.
When we're talking about the US clinical experience, a lot of medical students, including myself, I'm in second year right now, have this question in their minds that how do you find elective at a good hospital in the US? And what if there are visa problems and you are unable to go to the US? So what is the alternative to that?
So I would refer you to this. I was listening to this video by Manik Madan yesterday. He recently posted something about US clinical experience. I think it is very comprehensive. What are the opportunities for undergraduate medical students? What are the opportunities for graduate medical students? If you cannot obtain visa, and for example, your visitor visa is in processing and you cannot obtain that, then you cannot really do electives then, right? So what you can do is then you can see if you can do some scholarly work with someone by remote means of communication. And there are a lot of people who are doing those sorts of scholarly activities. So reaching out to them, engaging with them, and doing remote work. I know a candidate who is applying for a match. Her B1, B2 was in process, but with virtual means of communication, you can still participate in an interview. Hopefully she will match and she will get the visa, J1 or H1, and then she can start the residency. So opportunities are there. I don't want to spend a whole lot of time for something on that someone already has done a really amazing job. So go to YouTube, listen to Manik Madan. He has posted something on US clinical experience, which is really helpful. One correction in that was, and rest of it is just amazing, is the sub-internship. I think Dr. Madan talks about that sub-interns can do same as physicians or residents, they cannot because of their licensing issues. But rest of it is just amazing.
I'll add the link to the video as well in the description for this YouTube video so people can refer to that as well.
Sure.
When you're talking about the virtual interviews, what are your thoughts on the interviews going virtual, especially for IMGs in Pakistan? And as a program director, what do you look for in an applicant when you are interviewing them?
So I'm getting old, so I'm not going to be able to remember both questions. So let me answer one, and then we can move on to the second one. So for virtual interviews, I think, virtual interviews has helped candidates in many ways, because previously you have to be in US to do the in-person interviews, right? If you don't have your visa or you're having some sort of financial constraints, you cannot really attend those interviews. In an interview, if you have to get the either Amtrak ticket, or you have to get a bus ticket, you have to get a flight to get to the site of the interview, and then you have to buy hotel accommodation if you don't know anyone in that area. So it definitely has reduced the cost of being engaged in interviews, which has led to some negative impacts too. I think, for PDs and programs, they do like it in many ways too, because it's very easy to do interviews. Let's say if you're doing an interview, I can just sit in my office. I can do interview while I'm, I have some time from other things. It can be really difficult for programs to know the vibe that you get from meeting someone in person is different than doing virtual interview, right? So that part is lacking. And also, from candidate perspective, you really don't get to visit the place. When you're visiting that place, you can get that vibe, and you can really make an informed decision whether it's a place where you want to be, right? But I think another thing that happened is, because it has made an easier task to do interviews, it is less costly, it's less time consuming. There's a lot of unequal distribution of interviews at this time. So some people are getting a lot of interviews, probably the same people are getting interviews from many programs too. And some people are not getting that many interviews, because previously people would say, if I have 15 interviews, anything more than that, I'm going to start canceling those interviews. Now people can go to 20 interviews, though it's still, a little bit difficult because of the time constraints, and you have to take time off, especially for American medical graduates, because they're still doing their fourth year. So I think that has been a change. Now, to the second part of your question, would the PDs look for a candidate while doing an interview? So good news is that if you have received an interview, you have equal chances of matching compared to anyone else. PDs are looking at US as their future residents. So earlier I talked about an average psychiatry resident or applicant getting sending. So let me rephrase that. An average program receiving about 1,000 application, and they screen out roughly about 500. So your chance previously was 1 in 1,000, right? So when you get an interview, usually a program will interview 10 people against one spot. Community programs do a little bit more, 1 in 15 today. These days, they are doing 1 in 15 to 20. So your match chances increases from going to 1 into 1,000 to 1 into 70, 80, depending on the number of spots. What they look for is whether you can talk about something that you put on your CV. For example, we talked about some of the volunteer experiences and clinical experiences, whether you can talk about those experiences in an authentic way, whether you can talk about those experiences and relate to the program directors about the skills that you learned from being involved in those experiences. So one thing that look for is what is on the paper, whether it relates to what are they seeing virtually in person. The second thing they want to see for is the communication skills, whether this person can hold a conversation, whether this person can be engaged in a courteous, professional way of communication. And then there are other professional habits that can be picked, how you relate to other people on interview panel, program coordinator, how do you send your emails to the program, whether when you appear on the interview day, whether you're distracted, whether you're doing a lot of other things at the same time, whether you appear on the time for interviews. So all of these things really matter. But and I will also encourage all of you to read ACGME's core competencies, and maybe you can post some sort of link in this conversation. So ACGME has 6 core competencies: medical knowledge, patient care, system-based practices, practice-based learning, communication skills, and professionalism and interpersonal skills. That's part of the communication skills. So whether you are on track to learn those skills, obviously you may not have all those skills, but whether you're on track, whether you're teachable, whether you can be a good learner, and whether you can also be a good employee, because when they are recruiting you as a resident, they are recruiting you to serve 2 roles: a learner and an employee. So those are some of the things that they look for.
So, Dr. Naveed, we talked about the USMLE exams and all of the things that program directors look for. But when medical students enter medical school in the first, second, or third year of medical school, they're fairly new to the environment. So, what is your advice to students who want to pursue residency in the US and they're very early on in their medical school?
So I think one thing that we need to know is that USMLE is a path to practice medicine, right? Yes. So first of all, we are all physicians, right? Whether we stay in Pakistan or India or another country, or whether we come to US or someone is born here. So I think the most important thing is to strengthen your foundations of medicine, right? So a lot of good learning is happening in first, second, and third year. So first being able to ground yourself in those years and just focus on the learning in early piece and build strong foundations, because that's going to help you all through your career. So and this is why I think, in first 2 years, you cannot take USMLEs because a lot of foundations are being taught. And for IMGs, because you do study, especially in Pakistan, you study pathology in your third year and a little bit in your fourth year. So you want to really strengthen your foundations. And if you have strong foundations, then you can score very easily on USMLEs because the medical knowledge exists there. And half of the job is the test taking skills that you can learn by using different tools. If you have spare time in your hand, then we have, patient welfare societies. People can do medical startups, awareness campaigns, and being part of activities that can be really helpful. Because you don't only want to strengthen your medical knowledge, you also want a personality growth, right? Earlier, we referred that when it comes to American medical graduates, we have roughly about 4 to 5 years of lag, because they go to med school after they have done a graduation, 4 years college, and we go right from FSC, which is our equivalent to high school in US. As you will go in clinical years, or when you will start your clinical rotations, you will have an opportunity to communicate with patients too, right? So, how to communicate with them, that sort of reduces that power differential that exists between patients and providers. That's something that is very, very valuable too. So focus on developing that humanism, compassion, how you relate to the patients, all of that. I think that's very helpful in medical school years, not only during the first third year, because you're not doing many clinical rotations during those 2 or 3 years.
Thank you for sharing that advice, because I think it's really helpful. I feel that your foundations, as you mentioned, need to be very strong so that you can also perform as a better physician in the future.
Correct.
I think that brings us to the end of our conversation. Thank you so much for joining us, Dr. Naveed. It was an honor talking to you. I hope that we can have you on the podcast again soon. And thank you so much for coming.
Thank you very much. Thank you for inviting me. You're doing a great job. Good luck to you on your journey.
Thank you.